On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Health Literacy Webinar Series, Webinar Number 2, Managing Discharge or Transitions in Care. My name is Bob Yonish, and I'll be your moderator for this program. Now I'd like to introduce our first speaker for the webinar. Melanie Motz is a Patient Safety Liaison with the Pennsylvania Patient Safety Authority for the Eastern Region of Pennsylvania. Mel joined the Pennsylvania Patient Safety Authority in 2015 as a Patient Safety Liaison. She interacts with patient safety officers and other various healthcare staff in healthcare facilities across the Eastern Region of Pennsylvania in an effort to decrease patient harm. Previous to joining the Patient Safety Authority, she worked in outpatient and inpatient settings as a manager, educator, and registered nurse. Most recently, Mel was Director of Nursing and Patient Safety Officer for an acute care hospital in the Lehigh Valley. In that position, she led a team of nursing staff, case managers, laboratory staff, and clerical support, earning the CMS 5-star rating for quality of care provided and patient safety. She is from the Lehigh Valley, Pennsylvania, and is a graduate of St. Luke's University Hospital School of Nursing, where she received the Nursing Leadership Award. Mel also received her Bachelor and Master of Education degrees in Kinesiology, Exercise Physiology from Temple University, Philadelphia, PA, and a Bachelor in Nursing from Chamberlain College of Nursing. She's a certified professional in patient safety. Our second speaker is Dr. Maryleth LeBreton, nurse practitioner at Lancaster General Health, Penn Medical System. Dr. LeBreton is an adult nurse practitioner who joined Lancaster General Health Penn Medicine System in 1997, where she has been instrumental in developing clinical programs that have improved the safety and quality of life for patients and families. Dr. LeBreton received her bachelor's in nursing from Villanova University and her master's of nursing postmaster certificate from the University of Pennsylvania in the adult nurse practitioner program and a doctor of nursing practice from Widener University. During her tenure at Lancaster General Health Penn Medicine, Dr. LeBreton has had the opportunity to participate in numerous system-wide initiatives to increase patient safety and quality of care. Currently, Dr. LeBreton is a nurse practitioner in an innovative program called Care Connections. This team-based program is an interprofessional effort whose mission is to improve health care for the superutilizer population in the Lancaster General Health Network. Her capstone project, implementation of a validated health literacy tool with teach-back education in a superutilizer patient population, demonstrated the efficacy of including an assessment of health literacy and the teach-back method of patient teaching in this vulnerable patient population. Dr. LeBreton has worked with the Lancaster General Health Penn Medicine Patient Education Committee as chair of the Health Literacy Subcommittee to implement health literacy assessment across the organization and is working on implementing teach-back education across the organization. She's also working with the Care Connections team to implement transition of care visits to increase patient safety post-discharge from the hospital or facility setting. Mel, I'll turn the program over to you.
Thank you, Bob. Welcome to our second webinar in our Health Literacy webinar series. Today we'll be discussing how to manage discharge or transitions in care. Our objectives for today are to first define health literacy, describe the scope and implications of the health literacy problem here in the United States, identify barriers faced by both patients and clinicians in addressing low health literacy, and hopefully provide you strategies to enhance health literacy. Health literacy is the ability to read, understand, and act on health information effectively. Functional health literacy is the ability to apply reading and numeracy skills in the healthcare setting. Numeracy skills include being able to apply simple mathematical equations such as 2 + 2 = 4. This is important when dosing medication or calculating special diets such as carb-controlled diabetic diets or heart-healthy low-sodium diets. A person can have completed the required number of years of school and still have limited health literacy. In fact, approximately 45% of high school graduates have limited health literacy. Health information comes from many different sources and is delivered through multiple channels. The interactions between laypersons and professionals influence the health literacy of individuals in society. We're going to dive into how patients and healthcare professionals can better understand each other. You can tell someone's literacy level just by looking at them. A person may present themselves well, speak well, and appear to understand what is going on. However, this doesn't mean that they truly do. In terms of health literacy, universal precautions means to assume each patient has a low level of health literacy and err on the side of caution in making clear communications in plain language standard practice in all patient encounters. It's best to approach the care with the understanding that even those who are well educated may still struggle with health-related information. The language used in the health field is not commonly used in everyday language, and even those with good educational backgrounds may not understand what their diagnosis means or what's being asked of them. Even someone who manages health information well may have increased difficulty under certain circumstances. When a person is feeling anxious or overwhelmed with too much information, they may not be able to understand or use health information as well as normal. Think about a time where you were a patient or the caregiver receiving unfavorable health information. How did the stress of the moment affect your ability to comprehend the information, despite your own knowledge base? I can bet that most of you on this webinar have been in this situation at one time or another. I know I have been. At the end of the day, it's best to use simple, clear language to avoid any opportunity for misunderstanding. So there are 4 levels of literacy. These include proficient, intermediate, basic, and below basic. An example of health material that requires proficient skills is a table of information about health insurance costs based on income and family size. So basically having the ability to understand deductibles, co-insurances, what's covered under preventative services, etc. Adults with below basic literacy can solve simple additions problems. However, they would most likely have difficulty reading a chart or simple instructions. Additional studies have linked limited health literacy to misunderstanding instructions about prescription medications, medication errors, poor comprehension of nutrition labels, and mortality. This information was collected from home-based interviews with adults over the age of 16. Scores range from 0 to 500. Educators generally agree that adults need a skill at or above 275 to work with commonly found written materials, essentially those generally used for everyday life activities. Scores below 275 indicate that people have difficulty using print materials with accuracy and consistency. So as you can see here, the majority of adults, 53%, had intermediate health literacy. Only 12% had proficient health literacy, and among the remaining adults, 22% had basic and 14% had below basic. Adults who were ages 65 and older had lower average health literacy than adults in younger age groups. So as you can see, below basic and basic skills comprise a little over 1/3 of the adult population in this country. This population may be underserved in healthcare, or they simply don't understand what we are telling them when they do receive care. Education level and income does not necessarily indicate health literacy. Even highly educated, high-income individuals may not understand healthcare issues and how to maneuver through the system. We as providers take it for granted that these patients know what to do. So what do we know from a decade of research? We know that low health literacy leads to less healthy behaviors, underutilization of preventative services, poorer health outcomes, and greater healthcare costs. Remember, over 1/3 of the population has below basic or basic health literacy level. We can improve health status and understanding if we use specific communication techniques, which we're going to talk about today. A great quote from George Bernard Shaw: "The single biggest problem in communication is the illusion that it has occurred," which leads to our main topic for today. Why patient discharge? So these are general terms affiliated with discharge or transitions in care. Patient discharge or transition in care may be considered the most high-risk and vulnerable part of the patient care journey or pathway. It can make or break the road to a healthy recovery of poor outcomes, such as a complication, an adverse medication event, or a readmission to the hospital. Discharge is a multifaceted, multidisciplinary approach, and it's important to understand that it's not the end of the journey, it's just the start. So it may be the end of the patient's journey in your facility, but it's just the start for that patient in terms of their self-care or self-management process when they leave your facility. In the patient safety world, we consider discharge patient safety's perfect storm. 1 in 5 patients experience an adverse event following discharge. Typically, it only lasts a few minutes. Patients are being sent home or to another care setting on new medications, as well as changes in doses. There are commonly a number of follow-up appointments, dates and times discussed, and patients with intermediate or low health literacy are known to struggle the most at discharge, leading to poorer outcomes and an increase in readmission rates within 30 days. And financially, we're seeing a decrease in reimbursement rates from insurance companies. According to a literature review performed by Waring, Marshall, and Bishop et al. In 2014, they found there's the 28-day readmission rate for older people had doubled in 10 years from 2001 to 2011 from 103,000 to 201,000, suggesting that more needs to be done to support patient recovery following acute care. So how can we better manage discharge or transitions in care? We can use plain language, as we discussed in our first webinar series. We want to use language and in our written materials. We want to write them at a 5th grade level. We can use teach back, which we're going to discuss further today, and consider implementing Ask Me 3 from the patient perspective, which we'll also talk about. Mary Beth will later describe another evidence-based tool to get a baseline and health literacy assessment they've implemented in their healthcare facility. So it's important to assess the patient and family to determine how they best learn. Do they like to read information? Do they like to have a conversation? Do they like to talk about things? Are they audible learners? Do they like to watch video recordings? Do they like to listen to podcasts? You want to make sure you get that good baseline assessment before educating your patients. So that's very, very important before moving forward with any type of education. You want to speak slowly and in common language, and you want to utilize simple material, highlighting or underlining vital information. When we talk about how to teach, we want to match terminology and written materials to what is taught provided elsewhere. So if you are talking to a patient and you're talking to them about them, having a heart attack, you want to make sure you're using heart attack and not myocardial infarction. So if you're talking and speaking about heart attack, you want to make sure any supplementary written materials that you give the patient also indicate heart attack and not myocardial infarction. Or if you're talking about high blood pressure, you don't want to use hypertension. You want to make sure you're being consistent in your message verbally and in written materials, and essentially eliminate all medical jargon. Again, use plain language. So what is teach back? Teach back is one of the best practices to assess if patients are understanding what you're saying. A few extra minutes may make the difference between the patient doing a correct prep and showing up for the procedure. Ask the patient to tell you what they are going to do when they get home in their own words. Ask them to tell you what you just explained to them. We're going to be watching a video in a little bit of a good example of teach back. So here is a schematic of the teach back method. The idea is to explain the self-management or self-care process, assess the patient's knowledge by asking them to teach it back to you, to the clinician. The clinician can then clarify if the patient doesn't quite have it down, and essentially this cycle can be repeated until there's a shared understanding. I think the two most important steps here are to continually assess and clarify until there is a shared understanding. So you want to explain the self-management process, assess the person's knowledge by asking them to teach it back to you, repeat, clarify until there's a shared understanding. So you want to keep it as simple as possible. You want to give them action items, okay? You want to avoid unnecessary information. Remember to use simple language so they understand and can repeat back. Communicate with other providers so that conflicting information is not given, and get on the same page to make it easier for the patient to understand and remember the information. And you may want to consider using the Ask Me 3 questions, which we will talk about next. So the Ask Me 3 program is run by the National Patient Safety Foundation. The program gives 3 questions that patients can ask their healthcare provider during any visit or encounter. And those questions are, what is my main problem? What do I need to do? And why is it important for me to do this? So these are very simple, concrete questions. And you can get more information on the link I have here on the slide, the nationalpatientsafetyfoundation.org. So With the teach back technique, you want to limit it to the 3 or 4 most important things you want the patient to remember or do. You may want to highlight those 3 important things, circle, underline, whatever you need to do to make sure you're getting across that these are the 3 or 4 most important pieces of vital information you're giving the patient. You want to use open-ended questions to confirm understanding. Tell me how. Here are some examples. We've gone over a lot of information. What have we discussed? How will you make it work at home? Can you let me know what you heard me say? What will you tell your spouse about your condition? So you want to use those open-ended questions and avoid close-ended questions such as, do you have any questions? What's the answer you're most likely going to get? No. Or if you say, do you understand this information? You might get a head nod or a head shake of, yep, I'm good, I understand. So using those close-ended questions can really close off communication. You really want to use open-ended. And here are some more examples. What do you think will work best for you at home? I want to make sure I explained it to you correctly. Can you tell me in your own words how you understand the plan? How you will take your medications? Again, using those open-ended questions will deepen the communication between you and that patient. And now we're going to watch an example of the teach back method in this video.
The teach back method. The teach back method is a tool to help you confirm that your patient understands the information you discussed with them. After explaining a plan or a concept, ask your patient to state it back to you in their own words. Sometimes all it takes is a question such as, what are you going to do when you get home? Or, let's make sure I covered everything. Tell me what you are planning to do. To show you how it works, this video demonstrates the teach back method for a rheumatoid arthritis patient taking methotrexate.
So Betsy, today we're going to talk about your arthritis. Tell me how things are going.
Well, I'm feeling really stiff when I wake up in the morning. My joints are sore, and I really feel like I might be getting worse.
That's interesting. Are you taking your medications?
Well, yeah.
And you brought your medicines?
I brought them right here. I take methotrexate once a week, and I'm taking prednisone, but sometimes I forget to take the prednisone.
And so how many tablets of the methotrexate are you taking?
I take 1 tablet every Sunday.
So one problem may be that you're not taking the correct dose of methotrexate. It's very important to take the correct dose of your medicines. And here on the bottle it says take 6 tablets every week, and you'll take that on Sundays.
Oh wow, that seems like a lot.
Well, actually that's an appropriate dose for you, and you really should be taking all 6 tablets at the same time on Sundays.
Okay.
And the other issue is the prednisone, and you really should be taking prednisone every day.
Oh, you know, I feel like I gain a lot of weight when I'm taking the prednisone, so maybe that's why I've been forgetting.
Well, I understand prednisone can cause you to gain weight, but our goal would really be, once you're on the appropriate dose of methotrexate, to be able to taper the prednisone completely off.
Oh, that would be great.
Yeah, so hopefully we'll be able to do that. And let's talk about exercise. Are you doing any exercise?
Oh, not really. It just hurts so much. My joints hurt. I used to go to the gym, but it's just really difficult to run on the track or do any sort of aerobic exercise.
It's true that people with arthritis have a difficult time doing high-impact activities like you're used to doing. But even a low-level activity like walking or swimming can be really helpful to eliminate the stiffness and also maintain and improve the range of motion in your joints. So it's really important for you to be doing just a little bit of exercise each day.
Okay.
So I think we've come up with a good plan here today to how to move forward and treat your arthritis a little bit better. Just so that I make sure you've gotten all the information, tell me what you're going to do when you go home.
Well, I'm going to take my medication. I'm going to take the methotrexate 6 tablets every Sunday, and I'm going to take the prednisone every day. And then I'm going to start some exercise, some gentle exercise to get my joints moving, and maybe I'll get a friend to join an arthritis class with me.
That's a great idea. Are there any other questions that you have for me?
Well, if I do all this, how long will it take this therapy to work?
That's a good question, and every patient is a little bit different. But in general, most people start to feel better about 6 to 8 weeks after they start their methotrexate. So hopefully, if we institute this plan, that you'll be feeling better real soon.
That'd be great.
Good. So I'll see you next time.
Okay.
Great.
Moving on, this was a study. Researchers assessed whether or not physicians use the teach-back method during an office visit, and there was some interesting information that was observed. First, patients recalled less than half of the new concepts presented during the visit, so less than half of new concepts. Physicians assessed patient recall only 12% of the time. When physicians used the teach-back method, the patient was more likely to have a hemoglobin A1C level below the mean value, and visits that assessed patient recall were not longer. I think there's a myth out there that, using the teach-back method, may cause patient encounters to be longer, and that's not necessarily true. In fact, it may actually help you save more time and allow you to be a little bit more efficient in your communication. So when you confirm patient understanding, it's best to avoid questions such as, do you understand, or do you have any questions? That strategy usually leads to the answer of, you know what, no. Rather, we want to say, tell me what you've understood about this medicine, or I want to make sure I've explained your medicine clearly. Can you tell me how you think you will take this medicine? So how do you implement teach-back? First, you want all clinicians and non-clinicians to participate in using the teach-back methodology. So this includes physicians, nurses, physical therapists, clerical staff. You want to use teach-back upon admission to your facility by first assessing how the patient likes to learn new things. Again, getting that baseline can set the stage for educating the patient in general. You want to use teach-back not just at discharge, but throughout the hospitalization or encounter to teach the patient about new medications prescribed, how to do a dressing change, perform an injection, perform an exercise. Again, action items. Patients want to know what to do. This may help the patient better understand by the time discharge comes around. Remember, discharge starts on the day of admission. We always hear that. Discharge should not be the first time a patient is hearing about a new medication diagnosis. If anything, discharge should be reiterating all of the information you've already educated them on. You also want to use teach-back at discharge. So you want to explain the instructions, highlight or circle the 3 or most important items you want the patient to remember, assess the patient's understanding by using the open-ended questions we discussed in this webinar, and clarify and converse with the patient until there's a mutual understanding before they leave the facility. So bottom line, to use this on a routine basis through every patient encounter to educate the patient. And lastly, the last bullet point on this slide, AHRQ has a great 45-minute training module on how to train clinicians and non-clinicians on teach-back. So I highly recommend the AHRQ website, which the link is here for you to access in your slides. And I apologize, there's a typo that should say 45 minutes, not 45 training module. Though the AHRQ website does have volumes of information on health literacy, so I highly recommend that you check that out. And before I pass the presentation over to Mary Beth, I'd leave you one last thought. My thought is engaging in teach-back with our patients can only further enhance our communication with future patients. We learn from these continued patient interactions only to better our communication with the next. Okay. And Mary Beth, I will now turn the program over to you.
Thank you, Mel. I appreciate the opportunity to share what we're doing here at Lancaster General as we educate our patients. And hello to everyone that's listening. So health literacy and teach-back education at Lancaster General Health. We're also part of Penn Medicine New. So interested within the organization, we are very well supported by the executive committee of the organization, very interested in how can we educate our patients. May have actually been prompted from readmission numbers. Why are people returning to the institution? Why are they coming back with sometimes the same diagnosis? Did they not understand what we had educated them on when they were discharged the first time? So that's the big question. Do patients understand information for self-care? So we've identified that nationally and locally as a patient safety issue with frequent readmissions. What are the barriers to patients learning? We've learned that some people can't read. So therefore, when we're handing them written literature, they are unable to read it and may do better with pictures or videos. We need to understand the patient's level of understanding. and how to engage the patient in self-care. Engagement and empowerment are huge as far as having the patient be able to own into and have some accountability for their health care. So the health literacy initiative at Lancaster General Health came up actually with my Doctor of Nursing Practice capstone project. As I was looking for a project working with this complex patient population, the medical director said, we're really interested as an organization to find out what we're doing with health literacy and what people understand. So that prompted my thought process. I'll tell you a little bit about Care Connections. We have definitely an innovative team. We were established in August of 2013, was prompted by a grant from the state of Pennsylvania to serve a high-risk patient population. And the question is, how do we do that, and how can we help them understand how to care for themselves better and prevent readmission, therefore increasing their health? We have an interprofessional team. We have about 15 different staff members between physicians. Myself, I'm a nurse practitioner. We have 2 case managers because of the high volume that we have. And we have a pharmacist that sits on our team. We have chaplaincy that sits on our team. We have patient care navigators that actually go into the patient's homes. They're either LPNs, EMTs, and one's actually an exercise physiologist by training, but all doing very well to begin to understand this patient population. And new, we have a lawyer on our team that is supported by the IU13 grant, and she's been wonderful for understanding some of the legal aspects, people getting evicted from their homes, not able to get Social Security disability, things like that, so helping us understand the total person. We assess health literacy for every new patient and really begin to understand their style of learning, which often is not reading a piece of paper. I then took upon myself to educate the team on the health literacy tool that we were using to assess all of our new patients, and then educated them on how to use teach-back education. This was really important because as a team we were doing it, so everyone on the team was educating. In fact, one of the providers said to me, well, I don't think I need to learn this because I really don't educate anybody. And I said, well, have you changed any medicines today? And he said, well, sure. I changed insulin doses. I changed the blood pressure medicines. I said, do you know if the patient understood exactly what you were asking them to do or make changes? He said, I have no idea. That's a really good question. So he then we talked about teach back a little bit more. We then started using it, and he said, I think that method really works. So it's good. And then, of course, follow-up visits. Was the patient able to be compliant with the instructions? Therefore, I was able to implement the DMP project a couple of months in 2014, really looked at patient outcomes, and then since we had good patient outcomes, we were able to escalate this to the organization. These are the outcomes from my DNP project. So looking in the blue or the before, the first one is before ED visits before health literacy assessment and teach-back education was implemented with this patient population, and we found that 56% reduction in ED visits after we were understanding the patient's level of learning and then able to educate them with the teach-back education. Same for inpatient readmissions. We had decreased 55% reduction once using the teach-back health literacy educational pieces. So just in this, at Lancaster General Health, we figured if we could educate this very high-risk patient population, we could probably expand to the general population within the Lancaster community. So the health literacy assessment at LG Health, we definitely supported the Lancaster General Health executive team very much on board because understanding, how do people understand, and actually, interestingly enough, when this came up and actually came to the executive board, there was a board member who had a parent that was in and could really relate from being a parent, a patient's family member, and how did they understand, because he said, when I had no idea, my mother couldn't tell me what she needed to do, so we had some issues. So it really came from a different perspective, which really then brought a lot of buy-in. Patient Education Committee, it's a big initiative that we're working on at this point, and I will be honest and tell you from a health perspective, it does take a while to kind of get things up and running and rolling, get everyone on board. I also chair the Health Literacy Subcommittee, which is, we have a great group that works to figure out the how-to. We have some nurses from inpatient and outpatient that sit on the committee that really help to figure out how to do it on the working, the working people that do it every day. I'm also a member of a new committee. We have a readmissions committee, and we look at patients that have come in within 7 days. Why are they coming back to the organization so quickly? What's different? What's do they not understand? And health literacy has really been noted, and that we're really looking into patient education for is there a lack or is there a gap in that care when they leave from the first discharge. And also we evaluate health literacy on each readmission and kind of see where things are. And engage the stakeholders across the organization. Myself and my colleague, Jeff Klinkner, who I think is on this phone call, actually went and engaged the stakeholders across the organization, gave them actually two options, two choices of how to assess health literacy, and then let them make the decision. So therefore, we had a bit more buy-in because we asked for their help with what do they think would work best in their aspect of the organization. So the health literacy assessment tool that we decided on is an evidence-based tool, and we basically added the question that we're asking every patient on admission to the hospital or actually yearly in the outpatient arena. And the question that we chose is, how often do you need to have someone help you read instructions, pamphlets, or written materials from your doctor or pharmacy? And the way we chose to assess that is there's two levels of health literacy. I appreciate that Mel had mentioned there's four, but we thought that would be too confusing for the general population and the organization, and then what do we do with each of those pieces? So we cut ours down to two. We used the limited that has a score of 3 or higher, or an adequate score of 1 or 2. So this is our EPIC screenshot. We worked with the IT team. We used the EPIC electronic health record, and this is what they built. And this is how we see our question. And as you can see, it has numbers on it, and then as soon as you click on what the patient's level of health literacy is, this number automatically comes up, and then the beautiful thing is it goes right to our EPIC header. Now, those of you that use electronic medical records understand that the header has is very high state real estate as far as what needs to go on there, what's the most important information about a patient that we need to present so that everyone that sees this header, inpatient, outpatient, laboratory, x-ray, everybody would understand what the level of patient's understanding is. So this patient in particular has a limited health literacy. And so everyone around the organization is now aware. We engaged the EPIC development team, which was a pretty interesting thing. EPIC developers who live in Wisconsin had never left their building, so to speak. They'd never come out to an end user to see exactly, with all the pieces that they build in the electronic health record, how are they utilized? So apparently Lancaster General Health was asking EPIC so many questions, they sent 3 developers to do a site visit. They spent 2 days here across the organization. They had 3 different developers, and they kind of spread out all over inpatient, outpatient, just to kind of find out, what are you seeing, what are you doing, how are you utilizing our systems? A really neat thing was they had all 3 developers come to Care Connections and spend an hour with myself and one of our patient care navigators. And they asked us many questions. We kind of showed them our process, showed them our workflows. And we had a wrap-up meeting the next day with the EPIC developers before they left to go back to Wisconsin. They all 3 said, one of the most important things that we've learned is we need to understand the patient's health literacy before we can educate the patient, and it's just as important as the language that the patient speaks. If you'll notice on our EPIC header, the language that this patient speaks is English, and right underneath is limited health literacy. Their goal was, and their hope was, to take this information back to Wisconsin and present it as being part of their future rollouts for the EPIC electronic health record, noting the importance of everything. So that was a very cool thing for Lancaster General to be a part of. So one thing we have, as you saw in our EPIC Health header, when you click on that particular patient that we just saw with a limited health literacy, the question one of our physicians presented was, so what do we do with that information? So these are, when you click on that header link, strategies for limited health literacy come up. And there's some things that we basically learn as we engage with patients. Start with a warm greeting, make good eye contact, slow down when speaking, limit the content presented, as Mel had mentioned, just 2 or 3 things. What are the most important pieces that we needed to learn? Use teach-back education, which Mel had presented. Review the key points, and encourage the patient participation, which, just getting them to interact, so you have to take your pills. Well, where do you get your pills? Do you get your pills from the pharmacy? Do you prefer to have them in bottles, or do you use a pill box? How do you prepare your pills to take them the next morning? So engaging in what's particular and important to that individual person. And as Mel said, use plain non-medical language. So important because, as we've all had the patient interaction where the patient just nods their head and you think, oh, great, he understood. But then when you ask them something, you get that blank look and they say, maybe I don't understand, or I wasn't paying attention, is what we've heard most often. And so using graphics and pictures when explaining, as I had mentioned, there's a physician that had asked me, he said, we're giving all this information out and it's all written, but I was trying to explain how to take a new blood pressure medicine to a patient. I was explaining the side effects and things, and he looked at me, he said, you can tell me, doc. He said, you can give me that piece of paper, but I can't read. So the question is, what do we do with those pieces? And how do we handle those patients? Pictures, videos are coming out. They're becoming very up and coming in the patient education piece, so they'll be very important for patients. So the health literacy across LG Health, just now that we're able to document and utilizing the question, we're running reports on those. The inpatient assessments, they're assessed, I had mentioned, with each hospitalization for every patient, and this is age 18 and older. We're not doing the pediatric piece at this point because most often they have a caregiver or a parent that's handling that part, and we can ask the parent or the caregiver. Or if the patient comes in comatose, things like that, post-op type thing, then we wait, but we still do it during that admission. And what this has given us is we entered this as a hard stop in our EPIC electronic health record, so we have 100% adherence to that piece. On the outpatient side, as we're doing a yearly assessment, I'm not sure how many of you are working on patient-centered medical home requirements, but assessing health literacy is part of those requirements. So we're fulfilling that need. We've then taken, and since there are other questions that need to be asked on a yearly basis, we put them in as what's called the RAM questions. So those questions are gone through and asked every year, and therefore we fulfill the need of yearly assessment. And we're seeing the numbers increase about how many patients on the outpatient side are being asked this health literacy question as we have more patients coming in for their 3-month, 6-month yearly visits. So the numbers are looking really good. The organization, the staff is doing a very good job. So teach back education, we do know that it's evidence-based practice. And the most important thing is it occurs as part of routine education. As Mel had mentioned, any new diagnosis, any pre-op teaching, as far as even how to, appropriately cleanse themselves with whatever solution they're given pre-op. Post-op teaching, how do they manage what they've had, whatever surgery it is, knee surgery, hip surgery, belly surgery, whatever it is. Medications, of course, I think we all identify are huge because any little confusion in medications can change the patient and how they're doing. One thing we've really found is patients don't understand that they need to follow up with their specialist. So they've come into the hospital, they've had a heart attack, and they think they've seen the cardiologist while inpatient, but not always recognizing they need to see him on the outpatient side in the office too. Therapies, just reviewing with that, and I think therapies and diabetes management, they're very tuned into teach back education because they do a lot of demonstration, return demonstration from the patient to make sure that they understand. Another thing with our patient population is transportation to appointments. Sometimes a lot of our folks use the Red Rose access buses, and they have to call 24 hours in advance. So therefore, we do some teach back education as far as how do you come to the office? How do you get to the office type thing? Very important part of their care. If they don't show up for the appointment, they can't be seen. So some more on teach back education, evaluate the patient's level of health literacy, which I did mention was in the EPIC header. So do they like verbal? Do they like written? Or do they like pictures? Are they able to watch videos? Do they have access to videos? And then demonstration, as I had mentioned, is very important. Plain language, as we had mentioned, as Mel had said, not, have they had a heart attack, not, myocardial infarction. And the other important piece that Mel had mentioned is motivational interviewing, and it's part of the culture of teach back, if you think about it. Using the what and the how, and sometimes the why questions. I use these more now than I've ever used, and that's probably most of my patient interactions is using the motivational interviewing piece, and it's truly amazing what the patients will tell you once you ask them what they think. They do want to be involved in their care, so it's very interesting. Mel once again had mentioned the chunk and check, and that's the 2 to 3 really important things that they need to know as they're being discharged from the hospital, leaving from their provider's office with a new medication or new instruction. And TeachBack also, the most important thing is it allows to clarify the patient understanding. So what can they give you back? What can they understand? How are they going to do what they need to do in their own home environment, which is also oftentimes much different than the hospital piece. And we encourage use with all patient interactions. And then the other key piece is how do we document? And those of us that are nurses know if we don't document it, it wasn't done. And the other piece of documentation is how do we know then where do we pick up with the next piece of information? We look back to the documentation on prior episode and we can see what the patient understands, do TeachBack, and then we can move forward with more information for them. Once again, here's a picture of the TeachBack cycle, which works really well. Impact of patient education. With the TeachBack method, these are probably, I guess we gathered these are Care Connections numbers from the past month. So we looked at the patients we had in our program, so 12 months prior to coming to the Care Connections high risk program, and then 18 months after they had been with Care Connections. So did they utilize TeachBack education? Were they able to retain and then continue to follow out the instruction they had been given? Once again, it really empowers the patient. So this patient, 186 graduated patients, had a decrease in hospital readmissions from the time that they had left the program 18 months out, 54% decrease in hospital readmissions, which is truly huge, and 42% decrease in the use of ED visits from information they had learned from TeachBack education. And of course, decreased medication errors. And we, for the readmission committee, we've identified that medication errors are huge. So that's, further deep dive into what is causing the errors. Increase in outpatient specialty visits, as I had mentioned, and satisfaction data from Care Connections patients, 80% to recommend for other patients to become part of this program. And overall, improves patient outcomes. Role of health literacy assessment, TeachBack education, and our TOC piece. Organizational initiative for patient safety. We recognize that patients don't understand what they are to do when they are discharged, then we certainly can't expect them to we can't really hold them accountable for something they don't understand. So as Mel had mentioned, once they discharge the patient from the hospital or they leave from an office visit, they go to a different part of the continuum. So I remember in the old days before electronic health records, we had, my patients were the outpatients and the patients on the inpatient were their patients. Well, now the patients belong to everyone across the organization as we can look into the electronic health record and communicate inpatient to outpatient. It really increases the patient's health markedly. So it helps us identify potential gaps in care, understanding their diagnosis, self-care needs, their medication, which are huge. Anticoagulation management is also a good piece as far as Coumadin management. Wound management is huge as far as how to care for a wound to prevent infection. Fluid restrictions and dietary restrictions are very important with our CHF-type patients. So as we transition care, LGH developed a template to meet the requirements for the transition of care piece from a documentation standpoint, learning more about the patient standpoint, and also from a billing standpoint. So our template that we use across the organization talks about the admission and discharge date, where were they discharged from, or do they have and where did they go to, as far as did they go to a nursing home? Did they go to a rehab center? Do they have home health that they need to follow up with? And understanding, why is the readmission? So we're asking the patient, so why were you admitted to the hospital? Wondering if they understand that piece. Talking about the discharge of the facility, were they discharged from the facility in the last 30 days? As Mel briefly mentioned, there are repercussions from a reimbursement standpoint. If your patient's readmitted to your hospital within 30 days for the same diagnosis, you will not get paid for the current hospitalization, the readmission hospitalization. So detrimental from a financial standpoint. We just do a brief assessment as far as how are they eating, getting the fluids, are they sleeping, are they having pains, are they getting around from a mobility standpoint, do they have support at home? Is there someone that can be with them, answer questions, help them with things? We also do a medication reconciliation piece, which is very important. Do we have this? Are we all on the same page? Do our medication lists match the patient? Any lab tests or follow-ups that they need to have, and any plan of care for follow-up appointments. Very important. So we utilize this template. We call and we ask the patient this information to see what they understand. So, of course, paramount importance for patient safety. Upon discharge, part of the TOC requirements are a phone call, and Care Connections, we also do a home visit within the first 48 hours of discharge, though not counting the weekends. If a patient goes home Friday, you have Friday and Monday to get your call in. Use the same template, identify the potential gaps, and then there's also a TOC, transition of care provider visit, with the patient within 7 to 14 working days. So we have the patient come back in, we review all the transition of care notes with them, and then we have an office visit to review things again. Allows for coordination of care with specialists because we understand, what the heart doctor wanted them to do, or this is what the lung doctor told me to do, and then we can clarify with the patient and with the other providers. And, of course, evaluating patient outcomes. And that's about it, what I have at this point. I think, Bob, I'll turn it over to you.
Thanks, Mary Beth. That was a very informative presentation that contained valuable information everyone can use in their organization. That concludes our slide presentation portion of our program. Now we'd like to begin our question and answer period. Mary Beth, I see we have a question came in. What is the rationale of using the health literacy assessment whenever you're using a universal precautions approach?
We do. That's an excellent question. We do use the universal cautions approach, but we also want to tune into a little bit more what the patient is able to, how they're able to best learn. Are they going to learn from videos? We do ask the question, but then we say, okay, so how else would you, well, how do you better learn? And they know better than we do. But as far as documentation of a health literacy assessment, it just basically gives you basic guidelines of how to actually present in speaking, writing, or in video. Good question, though.
Another question. Is there a designated staff person who makes your calls? Yeah, well, actually anyone on our team for the most part. We have case managers that can do it. We have patient care navigators, our pharmacists are the main people that do it at this point. Okay. Another question. Have you changed the way you interact with a patient with limited health literacy? Absolutely. And I do employ the universal, now as I've gotten more into this, since my doctoral program and kind of learning more and then really seeing how things are going across the organization and interacting with more patients, I definitely use those techniques or those strategies that we had talked about. But I pretty much use them with everyone, but then I get a little bit more into the deeper dive of, could we use videos, could we use pictures? Or can you read this information? Oftentimes in the office, I will turn the screen and we will put up some information I'm going to provide the patient, and we'll look at it together and say, is this something you can do? Oh, can you read what this says? So not putting them on the spot, can you read this? But, oh, well, what does this say over here? So just kind of not putting them on the spot, so to speak, but engaging them and just kind of seeing if they can't then tell me what that says. And often I say, do you think we should look at some pictures? And then prompting that maybe that might be a better thing for them. Another question, was your intervention and study done with a specific patient population at Lancaster General? Yes, the particular one that I did was with our complex high-risk patient populations, so to better explain them. As we look at our patient population in all healthcare systems, there's pretty much a pyramid. Most of the folks stay at the bottom of the pyramid, but as we rise to the top of the pyramid, the folks that sit on the top are the ones that are our biggest spend, well, excuse me for saying that. They come in, they require the most healthcare services, they access the most healthcare services, and they spend the most money. So that is our patient population, the high risk. And as I had mentioned, the organization thought if we could implement health literacy assessment and teach-back education with the motivational interviewing in this high-risk patient population, we could be able to escalate it to the rest of the organization, use it with the general population, which seems to be going well as we continue to roll things out. Definitely. Another question. How do you deal with consent with patients that have low health literacy or low literacy in general? Yeah, that's an excellent question. As far as consent, we basically, since they can't read for the most part and or write, we ask if they can bring a family member with them, that someone that they can interact with can help them. And we're looking more as an organization into health coaches
So how can we help someone, support them? And then we will read, we will explain, and these take a little bit longer, but you read and explain, and then you ask the patient questions as you go through to do they understand, which is very important as we're having surgery and testing and things. So good question.
Let's see, another question came in. How do you follow up with residents who return to long-term care?
That's a good question. So if they are going from a hospital standpoint to a long-term care facility and they're staying there long-term, sometimes we send patients there for short-term rehab and they may transition into long-term. Then we will sign that off. We will discharge them from our program, so to speak, and send that off to the provider that's at the nursing facility. If they're going to the nursing facility, which we have many patients for short-term rehab, or they're going to the rehab hospital, we keep in contact with the case managers at those facilities and then find out when the patient's coming back home. And then we have a transition of care visit from the patients coming from the rehab or short-term rehab back to their homes, and then we do the transition of care using the information from that facility. And once again, we do find many gaps in care just from, medications and what's supposed to be, and do we need to get, home health involved, that type of thing. How do we best support the patient coming out of rehab, coming back to their home?
A lot of great questions coming in. Another one, are you finding any discrepancies on the discharge instructions with the TOCs?
Yes. In fact, we had a really good pickup last week in the office. One of our high-risk patients came in. She had been discharged on Wednesday from the hospital with a COPD exacerbation, so was receiving antibiotics and initially IV, and then we transitioned her to PO prior to discharge, and also some steroids. So I saw her in the office 2 days later, just was not feeling good. Was actually coming in to speak with our counselor and have some counseling done and do some advanced care planning, but we rolled that over into a provider visit. So as I saw the patient and reviewed medications from discharge and discharge summary to what she was taking in the home, she was not discharged on antibiotics. Hence, we knew we kind of needed to get on that quickly, so I restarted her antibiotics, continued her steroids, and checked with her over the weekend. Things were getting markedly better and feeling markedly better. So we are definitely picking up those pieces. Also, patients have medications that on discharge that are sent to the pharmacies, and we do that electronically now, and sometimes they are sent to a different pharmacy than the one that the patient uses. So we have to reconcile that and figure out where we need to get the prescription resent. Or we're finding patients are taking their old medicines and not the new ones prescribed post-discharge because they didn't see the importance of it. And we've also seen that patients, maybe were ordered some home health, some physical therapy, and by the time we call them in 48 hours, they hadn't heard from a facility yet or an agency as far as who was going to be doing that. So we make that connection to the agency, and, you're going to be able to call the patient and set things up so they get that support piece at home. And then the other big thing we're finding is sometimes they're unaware of the specialty appointments, as I had mentioned, seeing the cardiologist, seeing the lung doctor. Why do I have to see them again? I saw them in the hospital. Yes, well, they'd like to see how you're doing post-hospitalization, and then, sometimes we hear, well, isn't that your job? Well, that's my job too. So, yes, but we know we need to get back and get them into the specialists. Once again, increasing their level of care and increasing their health. And, making sure we have a lot of CHF patients, the congestive heart failure, so getting them back into that connection to the heart failure clinic, making sure that they're being seen there, getting their weights done, things like that. And I will say with being on the electronic health record, it's just wonderful because we can interact in basket, so to speak, the heart failure clinic saying, just letting you know, this is so-and-so's weight's up 2 pounds overnight. Let's touch base, let's make a plan before she leaves the office, and that is well received. And once again, good patient care and safe patient care.
Down to the last few minutes here. Are you applying these techniques to all patients or only certain populations?
We are in the process. We're certainly doing with Care Connections at this point. We are in the process of rolling out the Teach Back education, motivational interviewing to the entire organization. We are currently working on the strategy of the how-to. We know that physical therapy is just going to be, touch base with them because they do the demonstration. That's how the patients learn their physical therapy piece. But, yes, we're planning on rolling out to all the organizations, inpatients, outpatients, especially in the offices to, make sure that the patient knows what they're supposed to be doing when they leave the office. So, yeah, that's actually a work in progress as we speak.
Okay, and one last question before we end. Please define the high-risk population criteria.
So we have what we use is a red cap. We have built a system here, so they have to have 2 hospitalizations in the past 6 months. They have to have some social determinants. Behavioral health could be one. Inability to pay, from the financial standpoint. Insecurities as far as food insecurities, housing insecurities, things like that. So we continue to tweak, I will say. Care Connections is a very innovative team. We do change process as we feel we need to change process based on situations within the organization and the community. So those are our basic things.
Okay, Mary Beth, thank you so much for a great program. This concludes our webinar.